All right, good.
So this was they asked to do some sort of stroke education stuff. You know, that's kind of a broad subject. So I thought, you know, who doesn't love a little neuroanatomy at 8 a.m.? So we're going to just go through some anatomy. Hopefully the anatomy helps make some of the clinical presentations make more sense. If you guys have any questions at all, I am super informal. If you have any questions, just blurt it out. And I tend to talk fast and mumble, and I have a mask on. So if you can't hear me, just say, hey, what'd you say? Okay, and I'll try to slow down and do a better job of that. So without further ado, and we can get into more clinical stuff after all this is done, but I thought, you know, if you know a little bit more about how the brain works, it helps with what you're seeing in the ER. You guys are all ER? You are, what's your title, role?
A nurse.
Nurse?
Paramedic.
Paramedic? Okay.
Nurse.
Nurse, okay. I know you.
Yeah.
All right, cool. All right. So, crash course in the brain, right? So, neuroanatomy is not, generally speaking, straightforward, but there are ways to know a little bit about what's going on and maybe how that affects clinically what you might be seeing. So this nice colored picture breaks down the brain into the different lobes. And based on, obviously, what lobe we're talking about will determine what we might be seeing. So in the frontal lobe here, this blue in the front, you have personality, behavior, judgment, planning, higher motor functions, executive functionings. The speech, as in Broca's area here, is expressing speech, so getting speech out is in that area there, that brighter blue. The motor strip, which is kind of that periwinkle, if you will, is still the frontal lobe, but that's how you get your body moving. Impulse control and frontal eye fields are also in the frontal lobe, which is why when you see a stroke, sometimes in the ER, their eyes are deviated one way or the other. They are always looking at the side of the stroke because their frontal eye fields are involved with the frontal lobe there. The orange parietal lobe here interprets language, sensory. Again, that sensory strip there is a little bit redder orange. There's a lot of association areas in the parietal lobe. You get vision from your occipital lobe. We'll talk about that in a second, but there's a lot of association areas that kind of tie things together and kind of help you interpret what you're seeing around the world. A little bit of spatial perception as well in the parietal lobe. And the temporal occipital lobes, the temporal one here is green. You get memory, hearing, sequencing, and organization, and then you have Wernicke's area, which is understanding language. So there's two different types of aphasia, right? Expressive aphasia is I can't get the words out, and that's where Broca was there in the frontal lobe. And then receptive aphasia, or Wernicke's aphasia, means I can't understand what you're saying. So imagine waking up in a foreign country and everybody's speaking, but you have no idea what they're saying. That's receptive aphasia. So they don't really comprehend what you're saying at all. Whereas expressive aphasia is they know what they want to say, but they can't get it out. So not necessarily stuttering, but you can see that they're trying to say the word, they just can't get it out. So that's the two different types of aphasia that you may see, or language issues. Occipital lobe, its main job is just to interpret what's coming in your eyeballs. Light hits your eyes, goes back through the optic nerves, and then goes to the occipital lobe, and then it gets interpreted as to what you're seeing at that point. So a little bit different than the parietal lobe, where the visual association, it ties things together. I'm recognizing what that is because I've seen it before, I associate it with something else, versus the occipital lobe just says this light coming in looks like this. We're not going to go into all of these things because, again, nobody wants that kind of neuroanatomy at 8:15. But the brainstem here is what I really wanted to point out. The little, almost looks like a bird-shaped thing here, that's the midbrain. The outpouching of the brainstem is the pons, and then this part further down, before you get to the cervical cord, is your medulla oblongata. You guys ever seen Waterboy? Something's wrong with his medulla oblongata. So the midbrain has a few different, so we start getting to the brainstem and it gets a little bit hairier, admittedly. This is just a rough overview. So if this goes in one ear, out the other, it's okay. In your midbrain, you have some superior colliculi, which helps with your optic reflexes. You have the nucleus of cranial nerve 3, which provides innervation to a few of the extraocular muscles. The nucleus of cranial nerve 4 is the nucleus of cranial nerve 5, which provides innervation to a few of the extraocular muscles. The nucleus of cranial nerve 6 is the nucleus of cranial nerve 7, which provides innervation to a few of the extraocular muscles. You have your Edinger-Westphal nucleus, which is the parasympathetic innervation to the iris, so that makes your eye open and close. You have the red nucleus, which is good for coordination of movements. Your inferior colliculi, superior is vision, inferior is hearing. It's involved in auditory pathway. You have your nucleus of cranial nerve 4, which gives one muscle of your eye, the superior oblique, so SO4. You guys remember that from anatomy class at all? No? And then the mesencephalic nucleus of cranial nerve 5. So cranial nerve 5, trigeminal nerve, does sensation in your face. It also does a few other things. It has a few nuclei that run pretty much up and down the brainstem. So that's one of the nucleuses in the midbrain. In your pons, you have a lot of corticospinal tracts and pontocerebellar fibers that are crossing because your cerebellum is right behind it. You have motor of 5, 6, and 7. 6 does lateral rectus, so it makes your eyeball go out, look one way or the other. 6 is on the outside. And then 7 is facial muscle, so upper and lower face is 7. If you have a stroke or you have an issue with the nucleus of 7, it'll look like a Bell's palsy where it's weak upper and lower. Otherwise, if you have upper and lower, it's always a peripheral injury. That's one of the few places that you can have a stroke that looks like a Bell's palsy. You also have your vestibular nuclei, so cranial nerve 8 is auditory and balance. Several white matter tracts. A lot of what goes through the pons is motor fibers coming from your spinal cord, and also the spinocerebellar fibers that are crossing from your cerebellum. In your medulla oblongata, basically all the other nuclei of your cranial nerves, like 7 through 12, or 8 through 12 rather. There's a lot going on in the medulla. It's a very small area. I'll show you something at the end that shows why when you have a stroke in that area, some very interesting things happen, but we don't have to get too far into that. So we talked about, that's the structure of the brain, and this is the blood supply to those areas. So you have your, I'm just going to walk over here. So in the front here, you have these common carotids. About your jawline, they split into internal and external carotid. External goes to your scalp, about here. Internal goes inside your brain, aptly named. As it gets to a little bit above your pituitary, it terminates into the MCA here that feeds the majority of your brain. There's an ACOM, or anterior communicating artery, that goes up to your ACAs here. And then in the back, so this is the anterior circulation, and in the back you have 2 vertebral arteries that come up to your basilar artery that feeds your brainstem. This outpouching here is the pons from just the previous slide. And then at the top of the basilar you have your posterior cerebral arteries, and those connect to your MCAs or somewhere about there most times with the posterior communicating artery. So that's the circle of Willis, right? So anterior circulation connects to posterior circulation is that spider. Sometimes they have it in anatomy books, but that's the circle of Willis. Not everybody has an intact circle of Willis. It's actually pretty uncommon, about 30%. So some people don't have any posterior communicating arteries, and their anterior and posterior circulations aren't connected at all. Some people have one. Some people have posterior cerebral arteries that come off the anterior circulation. It's called a fetal PCA. So there's a lot of variation, but for normal, I guess, that's kind of what it looks like, or what it supposedly looks like. These are sagittal images through the head, like axial images through the head like this, and it kind of nicely color codes what arteries feed what part of the brain. So the red there is the ACA artery, the yellow is MCA, green is PCA. In those other pictures, the orange, the LSA stands for lenticular striate lenticular striate arteries. They're tiny little arteries that come off the MCA, and I got a picture here in a minute about those. And then the blue is anterior choroidal artery, which is another artery that comes right at that carotid terminus where the MCA breaks off. There's another artery that kind of goes off and comes back. But for the most part, MCA, ACA. ACA, we'll get into a minute of what is, someone get ahead of myself. But yeah, that's the vascular supply. We talked about these lobes. I don't know why I put a picture in there. So a little bit closer picture inside the brain. From the previous picture, the carotid arteries would be coming up here, and they terminate right at this hole they got cut off. And then you have your MCAs coming out, and they branch. The MCAs, we give it numbers. From here to this branch point is M1, and then from this branch point to probably right about here is M2, and all these out here are M3. So if you ever hear M1 occlusion or M1 something, that's what they're talking about, is the first part of the MCA right here. And then these arteries are the lenticular striate arteries I was talking about that feed, oops, wrong way, that feed this area here off the MCA. And if you were to look at the outside, if we're looking at this side of the head, kind of this is how it feeds the cortex. So the arteries come up underneath your brain and they go out and feed the outside of your brain, okay? There are some smaller arteries that feed the deeper structures here, but this area here is all ACA, and this area back here is all PCA. And there are connections, or not connections, but capillaries between MCA, PCA, MCA, ACA. And when you have decreased blood flow because of a blocked carotid or your heart stops or whatever it is, you can have what's called a watershed infarct. And a watershed infarct just means that if you have 2 sprinklers in a lawn, if the pressure is high enough, you're going to get the middle part of that lawn if they're on each side. If the pressure drops, that middle part doesn't get watered, and that's a watershed stroke. So it's really the spots in between these arteries. So along this line here is where you would see what's called watershed infarcts. No, yes, the homunculus. Everyone loves the homunculus. It's a weird looking person laying on your head. But this kind of correlates both what we just talked about, vascular territories, and maybe clinical findings. The MCA feeds the vast majority of your lobes. It's a pretty important artery. We like to keep that open in stroke. Try to keep it open as much as possible, but ACA is leg and trunk here. You don't really need that much to keep yourself upright. You just need these things. We use our hands for a lot and our face for a lot, so there's a lot of cortex that is dedicated to these things, which is why it's also hard to have like facial droop and maybe some leg weakness by itself. That's going to be a cortical-based stroke, right? So if you're going to hit this part and this part, you're going to also do your arm and hand. So a face and a leg together is not impossible, but it's probably going to be a deeper structure down deep. It's not going to be something cortical. And then this green back here, like I said earlier, this will go back to your occipital lobes and feed a lot of the, not only the bottom part of your temporal lobe, but your visual interpretation area. Motor and sensory look almost exactly the same. Obviously, because we use our hands so much, a little bit more motor dedicated to your hand than sensory. Fair amount dedicated to your lips for sensory, and your tongue, where you don't really need to move them as much, but it's very similar. Questions on that? All right. The posterior circulation, kind of like the brainstem, gets a little dicier. When we talked about the carotid arteries a minute ago, that's all in anterior circulation, so that's all coming from the front. The posterior circulation is those vertebral arteries that come up into the basilar artery. Here's your verts here on this picture, so this is an anterior view, and this is a side view. They're called vertebral arteries because they come up in vertebral bodies. There's maybe in between the vertebrae, there's a spot for them to come up, and they're kind of protected. And then about the cerebellum, they take a dive into the dura, which is the covering around the brain, and then they become essentially intracranial at that point, and they wrap around to the front of the pons. When they come together, they make this nice big fat artery called the basilar. This is also very important to keep open. Blocking this is usually not compatible with life. So posterior circulation strokes are a big deal. There's a lot of other arteries that come off of the basilar. These smaller ones are just called pontine perforators. This one near the top is the superior cerebellar that feeds the top of the cerebellum, aptly named. Your inferior cerebellar comes off of your vert down here. There's an interesting stroke syndrome that comes from pica, so this little artery here. And then it terminates in the posterior cerebral artery that I kind of showed you in the other one. And it should connect your anterior circulation with posterior communicating arteries. Should, but not always. And those are delineated here. So right in between the SCA and the PCA, this is cranial nerve 3. So this is how you can have, I don't know if you guys have heard of this before, but if you have an aneurysm on this PCOM artery, it can compress that third nerve. So we're kind of looking up at it a little bit. This is right here. If it was on this picture, it would be coming out right here. If there's an aneurysm in this artery, it'll compress on this part of the nerve, that part of the nerve, the outside part of it, is where the Edinger-Westphal nucleus fibers run, so the parasympathetic fibers. And so when you press on that nerve, you get inability to constrict your eye, and so you have the blown pupil, right? So sometimes anisocoria or unequal eyelids, or eyelids, unequal pupils can sometimes be, if it's new and it's acute, one of the things to think about is an aneurysm in this area that might give you that. This is brainstem anatomy again. This is unnecessarily complex for this early in the morning, and I understand that. This is just to demonstrate that there are a lot of things going on in the brainstem. That basilar artery would come right down the middle here and feed the majority of this with its pontine perforators. And then your medulla gets a lot of its supply from the pica that came off the vert. So 2 different types of stroke. I get this a lot too, whether it was a bleeding stroke or a clot stroke, right? So a hemorrhagic stroke is less common. It's only about 15% of strokes that are bleeding strokes. And it is something broke, right? So a blood vessel ruptured and you have extra blood inside of your head that shouldn't be there. It is a space occupying lesion, so it kind of pushes things out of the way. You can have 2 different kinds. Ones that are inside of the brain called intraparenchymal, and then ones that are between, well, underneath the arachnoid called subarachnoid strokes. And there's blood basically that goes in all these crevices, but it's not inside of the brain tissue itself. The other type of stroke, which is the more common that we see, about 85% of strokes are the clot strokes, and that's demonstrated, I guess, kind of here. If you have plaque already built up in an artery, and then you have a thrombus that came from somewhere and blocks it off, then everything that's distal. So if this is where the blockage is, if you remember back, this artery comes out and feeds this whole part of your brain on the outside. So everything distal to that is not getting blood flow. The arteries are literally like branches of a tree. You have your carotid, MCA, and as you go out, you get the smaller limbs. But if you block it here, there's nothing feeding out here, right? There's no retrograde flow. If you block it here, it's not going to go back down your carotid, just because the pressure in your arterial system is going to push it. It's going to want to push it one way, and that's to the distal little pieces, or the twigs, as it were. But sometimes it gets stuck in these bigger branches and limbs. And that causes a lot of issues. Looking back at the homunculus, and we'll talk about this in a second, how much of that is fed by that MCA is important. Aneurysms are different. Aneurysm just means it's an outpouching in the artery. It's just arteries have the makeup of their walls. There's some smooth muscle and there's some other collagen in the walls. When those get weak, they kind of stretch, right? And that's what they're supposed to do. Because when your heart is beating, they're supposed to do this, which is what all the arteries do. But when they get weak in one particular spot, they can outpouch, and that's what an aneurysm is. That aneurysm is a thinner wall than normal artery, so it can be more susceptible to rupturing. And that's where you get your subarachnoid hemorrhages from. Aneurysms of a certain size, they'll go in and fix, like 10 millimeters. Anything smaller than that, it's not really that exciting. They kind of just watch it. A CT angiogram will pick up 2 and 3 millimeter aneurysms. The resolutions are good enough to see really, really small aneurysms. We just kind of watch those. So in a ischemic stroke or a clot stroke, ischemic stroke, some of the patients like to say, what happens here? So when you don't have blood flow to neurons, you get impaired energy metabolism and you get depolarization, so they stop working. You get a buildup of calcium in the intracellular space, free radicals, acidosis, things start to build up, and those waste products start to wreak havoc on the function of the neuron itself. Normal blood flow is about 50 to 60 milliliters per 100 grams per minute. When it drops below 20, there's a loss of what's called electrical activity. So there's an electrical failure threshold. Those calcium intracellular, in the intracellular space, lactic acidosis, and other free radicals, they build up enough to where the neurons stop working. And that's the electrical failure. If blood flow drops below 10 milliliters per 100 grams per minute, you stroke. So there's cell membrane failure and the cell dies. So you can have electrical failure before the cell dies. So you can have symptoms like the neurons stop working, but it doesn't necessarily stroke. And this is hugely important because of this, right? You guys heard of the word penumbra? It is the brain that is at risk, literally. It's where part of your blood flow has been interrupted and you've reached that electrical threshold, so you have clinical symptoms, but you haven't reached that cell death threshold, so you haven't stroked yet. So that is the brain that is at risk, so if you don't get blood flow back to that area, those cells are going to die and you're going to have a stroke. But you can have the symptoms and just have penumbra, or just have brain tissue that is at risk. This is not an all or none phenomenon. It matters amount of time. So if you're at 5 milliliters per 100 grams per minute, you'll stroke in about 30 minutes, right? If you're at 5 to 15, you might, the cells might last 1 to 3 hours. So this, if there's some blood flow through it, you're gonna last a little bit longer than obviously if there's absolutely zero. But it's not as soon as the blood flow drops, everything past this dies. It starts to slowly stop functioning, and if you don't get that blood vessel open and reperfuse this area with fresh blood, then it's going to die. So this is all about stroke. This is why it's so important to treat stroke as soon as possible. The longer we wait, the more cells die. The longer, even if a patient looks really, really bad when they first walk in, if they're still within that, if it's all penumbra and we treat them, we could limit how much damage is actually done. Because electrical threshold doesn't mean the cells aren't going to come back, it just means they stop working. Once it gets to cell death, then they're dead. Then we can't do anything about that. So we try to avoid that as much as possible, this is all why time is brain, right? Those are all over all of our boards. Time is absolutely brain because of this right here. So we're going to try to tie some of the anatomy in with the vascular territories and in with the homunculus and what the brain actually does into some stroke syndromes. So MCA, the big one. MCA, like we said, feeds the vast majority of this yellow is quite a bit. The vast majority of your brain. You have motor, sensory. You also have some deeper structures called the internal capsule, your infraparietal and your lateral temporal lobe. So it feeds quite a bit. When you have an MCA stroke, you have contralateral or opposite side hemiplegia and hemiparesis. Hemiplegia is no movement, hemiparesis is weakness. So you have contralateral weakness, contralateral hemisensory loss, and eye deviation towards the area of the infarct. Because we talked about those frontal eye fields in one of the earlier slides. You look towards the side of a stroke. So if you're having a right MCA stroke, contralateral can't move, contralateral can't feel, but you're going to look towards that side of the stroke if it's an MCA stroke and it's involving the frontal lobes. The frontal eye fields just push your eyes the opposite way, which is why you look towards the lesion. And that's if it's an M1 occlusion. And we talked about a little bit, M1 is down here. So that's an occlusion here that gets all of this. If you're a little bit further out and it branches already, you have M2 that branches into an anterior, posterior, inferior, superior division, depending on which book you're looking at. But basically the MCA branches and part of it goes to the front of your brain, part of it goes to the back of your brain. If you hit the superior branch, you're going to get more of your motor and sensory strip and hit Broca's area here. So this is your superior branch right here. If you hit your inferior branch, you're going to hit more visual association areas back here. Maybe get some Wernicke's aphasia as well, or not be able to understand language. Yeah. Any questions on any of this? You guys are full of questions today. All right, so this is Wallenberg syndrome. I threw that anatomy brainstem picture up there earlier to just demonstrate that there's a lot going on in the brainstem. When you have a stroke, we don't have a lot of procedures in neurology, so we name stroke syndromes and other things after people. So Wallenberg described this. This artery that comes off the vertebral artery, the posterior inferior cerebellar artery, or pica, feeds the bottom of your cerebellum and the vast majority of your medulla. Your medulla oblongata has, it's from right here down. Actually from right here to right here, because this is cervical spinal cord here, but this is your medulla oblongata. You have a lot of important nuclei that run through here, 9, 10, 11, and 12. 11 actually comes from some of the cervical, but 9, 10, and 12 come out of the medulla. So vagus nerve, tongue, and some palate issues with 9. 8 comes off of 8 and 7 come off right between the pons and the medulla, and it's actually fed by the pica as well. So there's a lot of cranial nerves that are involved. And when you have a lateral medullary stroke, you have Wallenberg, and you have all of these things because of all that important stuff that's running through there. This picture is better. This is a cross section of the medulla with some nice crayon drawings to make it easier to see. But with the Wallenberg syndrome, you actually get opposite findings. This is one of the few places in the brain that you can get pain and temperature on one side of the face and then the other side of the body, so contralateral crossed findings. That does not happen in a lot of places. The medulla is one, because right about here is where the fibers decusate or they cross, right before the medulla. Some of these are still ipsilateral down here, so you'll get some same side. You also hit the spinal trigeminal tract and nucleus. This is the trigeminal nerve that I talked about did the sensory to the face. The nucleus that covers that sensory, that it does other things as well, but that nucleus is in this part of the medulla. It runs up and down the spinal cord. Here. Which one? It's this long one here. That's the spinal nucleus and tract of 5, which is involved in sensory of the space, which is why you get the crossed findings. You hit your vestibular complex, you hit solitary tract nucleus, you hit your dorsal motor nucleus of 10, you get hiccups, you have a lot of vomiting, vertigo, ipsilateral cerebellar signs, contralateral motor and temperature signs, palatal myoclonus, so your palate will do this sometimes. Ipsilateral deficits of pain and temperature we talked about. Difficulties, because you're hitting 9 and 10, you're having difficulty swallowing, dysphagia, hoarseness, absent gag reflex, and you can also have an ipsilateral Horner sign. So there's a lot going on here, and these patients don't necessarily always do great. They usually have problems swallowing, nystagmus, hiccups is a big thing. It's a small stroke, but it's in an important area of the brain, and it's a lot of important things. It can be very debilitating. We had a guy here not too long ago. He was a young guy who went to an outside hospital, and they admitted him for, I think he just had vertigo, maybe some weakness initially, and he refused TPA. They admitted him there, and then he worsened overnight, so they transferred him over here, and then he worsened again. But basically he was slowly completing his lateral medullary stroke, and he just kept getting kind of worse and worse. He started to develop hiccups, he had dysphagia, I think he left with a peg tube. But yeah, it was unfortunate. He was, I must say, late 30s, early 40s. He was a young guy. So he was also a little bit of a vasculopath. He smoked a pack and a half, 2 packs a day. Had coronary disease and didn't take his medications. And, yeah, so he had a long road to rehab. I'm actually curious as to how he did, but not great. Horner syndrome, something you can get with the medullary stroke, is the triad of ptosis, meiosis, and anhidrosis. So you get a droopy eyelid, that's the ptosis. You get meiosis, which is the smaller pupil. It looks like in this picture that the left pupil is the bigger one, but that's really not the issue. It's the right one that's the smaller one. And then that side of the face, you have anhidrosis, so you can't sweat on that side of your face. So that's a Horner syndrome. You can have a few different spots where this is a lesion down your cervical chain. It wraps around. You can have a lesion in different spots that can give you a Horner syndrome, but that's also another syndrome or a triad that you might see in the ER. Any questions on any of that? I'm going through this kind of quick. Still no questions. You guys are good. You guys know all this stuff, so this is redundant. I understand. I apologize. So there's a lot of stroke mimics, right? There's a ton of stroke mimics. Basically, anything that can affect your neuronal function on a cellular level can cause neurologic symptoms that look like a stroke clinically. Okay, and that's just true. That's the 20-30% margin. If we're giving TPA like we should, about 20% of the people that we give it to are not going to be having a stroke. They're going to have stroke symptoms, but they're going to be having a stroke mimic, and that's okay because TPA is actually really good for you, and it's not going to harm you. Right? If you're not having a stroke, the chances of it actually harming you are really, really, really low. Not zero, but really low. But different things that can look like a stroke. Postictal TOTS paralysis, like you're weak after a seizure, one side doesn't move. Syncope all the time. You pass out, you kind of come to a little bit, you have some slurred speech, maybe maybe you had some transient weakness, who knows. That gets called a TIA or a stroke quite often, or looks like it when it first comes to. Some infections can do it. Some headaches do it, right? So we have what's called a complicated migraine. Like it's basically a migraine that has stroke-like symptoms. You don't have a stroke, but you can have weakness, numbness, slurred speech, confusion even with a migraine. You can have some space-occupying lesion, some tumor, something that causes dysfunction. Metabolic causes hypoglycemia, absolutely. Slurred speech can cause focal weakness as well. Hyperglycemia sometimes. Spinal cord disorders, peripheral vestibular disorders. So we talked about the posterior circulation coming in. Somebody, if they're having cerebellar findings or if they're having internal or inner ear dysfunction, that's the big one in the ER as far as is this a posterior circulation stroke or is this just inner ear dysfunction? That's a whole nother talk. But these are all the stroke mimics that you might see as well.
Dr. Ellison?
Yes?
I've heard that those complex migraines actually increase the risk of stroke.
They can. So there's something called migraine with stroke. So the pathophysiology behind migraine is interesting. There's a little bit of spreading depolarization, but there's also a vascular component to it. And there's some vasospasm essentially with a migraine. And there are people who have maybe some thinner posterior circulation, and migraine might predispose them to having stroke because of that. Migraine or stroke with a migraine is a thing. It's not super common, but it can increase your risk for stroke as well. At least there's some association there.
That's why that one young guy that keeps coming in with those complex migraines that are so convincing his stroke, he's had TPA, I believe, 2 or 3 times.
Yeah.
But how do they know? How do you tell your patients what to do?
Well, you can't. I tell people just come into the hospital, and if you come to the hospital 100 times, all right, let's not say 100, let's say 10 times. You come to the hospital 10 times, and I treat you with TPA, and you're fine 10 times, then great. If you come to the hospital 8 times, and 2 times you stay home, and one of those times was a stroke, guess what? I can't do anything about it. So we either go through this multiple times and treat it like it is a stroke, or you stay home the time it is a stroke, and we couldn't have done anything. We've gotten a lot better at treating acute stroke, so we can treat stroke. Well, let's go off on a tangent here since we have a few minutes. The NINS trial came out in the 90s. The NINS trial is what is a big trial that looked at TPA to treat stroke. Prior to TPA, you came in with a stroke, we had kind of a fatalistic mentality. Oh, you've had a stroke, I'm sorry. Sometimes we put people on heparin just because it made us feel better. We've come to learn that that's not the best thing in the world to be doing. But before TPA, there's not a whole lot we could do. So when TPA came around, it's like, hey, there's something we can do that works some of the time. It's not perfect, but it works some of the time. And so that was 20 plus years ago, and now we've been using TPA for a while, and that's been FDA approved. If you get somebody within 4.5 hours, we can give them TPA to try to break up a clot, and they might get better, right? We've also gotten better in the last 10 years at thrombectomy, so going in and fishing out a clot. TPA works 30-ish% of the time. Some clots are too big, and the larger vessels, so if you have a big one sitting in your MCA, it may not break that up, may or may not. And so the instruments and the technology has improved over the past 10 years, and we've had some more studies that show that, hey, we can go up there and try to fish it out within a certain time frame. We can't do it after 24 hours. And they have to have certain imaging that shows us they have some penumbra or some brain at risk that's worth going into after, which is what the rapid imaging does. The rapid imaging basically tells us this is how much stroke is already dead, and this is how much brain is at risk. And so if those numbers are favorable, and it's in an artery that we can get to, then we'll ship them down to Methodist and say, hey, fish that out, please. And hopefully prevent them from having a big stroke. They might have a smaller stroke, but the idea is to limit the size of the stroke. All that is to say, TPA, thrombectomy, we've gotten better at treating acute stroke in the first 24 hours. After that, nothing we can do, right? What's done is done. We deal with the aftermath, we get you rehab, we try to get you stronger, and then we try to prevent. Stroke is all about prevention, or the majority of it. Because once brain cells die, they don't come back, right? They don't regrow, they don't regenerate. This isn't your liver. Your brain will rewire to a certain extent. Neuroplasticity says that you can kind of rewire, relearn how to do some things, but you can't relearn how to see, right? There are some things you can't relearn. you learn how to talk and walk at one point, you can relearn how to do those things, but you can't relearn how to see. You can't relearn how to hear. Some of those things are hardwired. So we try to prevent strokes as much as possible, which is why Margie and I are big on, well, you guys are in the ER, but if you, inpatient-wise, once they've had a stroke or they've come in with stroke symptoms, you know, the secondary prevention measures, right? Antiplatelets, statins, stop smoking, diabetes control, all those things we harp on with every patient to try to lower stroke risk as much as possible, because if they have stroke and they come in after 24 hours, you know, all I can do is try to help you get better and then prevent the next one. So, but acute stroke wise, I could give a whole nother lecture, and I have a whole nother lecture on the treatment of stroke. I didn't get into it too much here. You know, for a first lecture, I thought maybe knowing a little bit more about the structure of the brain and what does what helps maybe what you're seeing clinically as far as weakness, numbness, visual field cuts, and those types of things. If it makes a little bit more sense because you have a little better understanding of the structures, then we could move a little bit further and down into treatments and other things that are going on. I said a lot of words. You guys have any questions? No? All right. Well, that's about 8:45. There's no other questions on anatomy or stroke pathology. I think that's all she wrote. It is, look at that.